Welcome to our fifth class. We are now to patient assessment. Everything revolves around this. Being an EMT, you respond to the call. Make sure you get there alive. Make sure you don't get yourself hurt or anyone in your team hurt. Make sure you don't make your patient worse. Do a good assessment. You look at the positive findings of the patient assessment that you're going to learn how to do tonight. Based off the positive findings, you form a primary impression, general impression. And then choose a treatment protocol based off that general impression. You get the patient to definitive care. Any questions? What's definitive care? Ooh, I'll be asking that at the end of the night. None of you have 10 out of 10. It's getting the patient back to what they were prior to the incident. Huh? You do not. You have not. You have chapter 6. You do not have 10 out of 10.
You said on the night before's lesson.
No, I said all of you have to have 10 out of 10 on all of them if you want to go home early. You don't like it? You can bring it up with the guy that makes the rules.
I just did.
You said definitive care is
Definitive care.
getting a patient
Back to what they were prior to needing your help. I would say getting them back to normal if most weren't normal before. All right, so we went over teamwork last chapter. This is an excellent example of what a team should be like. Battleship, that's what it should be like. Oh, that's kind of cool. Your team will only be as strong as your weakest link. That's what team support looks like. All right, there it is. Start always with seeing size up. Then primary assessment. You do not proceed past the primary assessment until you have ensured the airway is clear and secured, breathing is adequate or being ventilated, and they have a pulse, or you have started CPR or stopped any uncontrolled bleeding. Then you move to history taking. Then your secondary assessment with vital signs, and then reassess to see if your treatments are working. Any questions on the steps? All right. Scene size up. You're going to get your dispatch information. You're going to survey the scene as you're arriving. You're going to look for hazards, safety concerns. Mechanism of injury is a huge part of this. You're going to learn a lot about it and have a lot of questions. Mechanism of injury is what happened, what caused the traumatic injuries. If it's not a trauma, then we look for the nature of illness, what's making them sick. Mechanism of injury is critically important to determine so that when you bring them to a trauma team, the surgeons know where to cut first based on the type of injury and how it happened, where the force was applied and what type of force. You're going to need to know what the chief complaint is, how many patients, and based on all that, are you going to need to order additional resources? Do you need more ambulances? Do you need more fire rescue people? Do you need law enforcement? Do you need the power company? Do you need a tow truck? What do you need? Any questions about scene size up? And BSI, Scene Safe BSI. We're gonna make sure that we isolate ourselves so we do not get contaminated and get sick ourselves. Any questions? All right, scene safety. I really don't remember what this is. And I'm logged out of Facebook, so you're not gonna learn what it is either. I don't remember that video anyway. All right, potential hazards, oncoming traffic. Traffic collisions and being struck by cars is the number one line of duty death in all emergency services, EMS, fire, and law enforcement. Unstable surfaces cause people to get hurt all the time. Leaking fuel down electrical lines. Violence. Violence is constant. Fire, hazardous materials. Other dangers at a crash rescue scene. Just because one car crashed doesn't mean another car is not going to do the same thing and crash into you while you're at scene. It happens all the time. And of course, crime scenes. Poo, 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 poo. People do come back and shoot again. Always be aware. Any questions? One of my favorite stories was a medic I still work with sometimes. He's not a medic anymore, but he's volunteer fire. But he was working in Alameda, and they were on a gunshot victim. They just put the guy in the gurney and they were taking him to the ambulance. And a bystander walked up to him and said, "Is he dead?" And he said, "No." He says, "Is he gonna make it?" He goes, "I think so." He goes, "Okay." Reaches in his jacket, pulls a pistol out, shot him 6 more times on the gurney. Scene security. Any questions? You never know what's going to happen at a scene. How could a simple 4th of July party turn dangerous? You just never know. You got to be watching out. Just because the scene begins safe doesn't mean it will stay safe. Law enforcement's always going to be in charge of the scene. Your safety and your team's safety always comes first. Any questions? This next one's important for you guys to watch. This does happen. This is why you let cops secure the scene. You guys aren't allowed to do that. This is what you got to worry about here. For scene safety, nobody slows down. You're pulling into a car accident. You have to deal with this. Or same one. All right, mechanism of injury. What you want to know is what type of force, the amount of force, how it was applied to the body, and where it was applied to the body. And here's some examples of mechanisms of injury. Hold my beer. The nature of illness for medical patients, what appears to be the type of illness? Any questions? For example, why is this guy's voice so high and all the rest of the guys' voice is so high? Yeah. There you go. Any questions? I understand nature of illness. Kind of a mechanism injury at the same time. Oh, looks like we got another one. Oh, this is great. Listen, listen. That's a tip fracture.
Oh my God.
Oh, shit, God help me right now.
Hold your hand. Shit.
That's a distal tip fib fracture. That's what it sounds like. Want to see it again? Hear it again?
Oh my God.
Oh, shit, God help me right now.
Hold your hand. Shit.
Questions? Can't laugh at that. That's a serious injury. Then you want to know number of patients. Sometimes you can get more than one. Questions. Same thing. Is this a secure scene? So, if you're not working as an EMT, you get in a car accident, do not get out and walk around in traffic. Vehicles traveling at 60, 70 miles an hour are fatal when they strike you. You'll be amazed. The people that grab their kids and get them out of the car, be inside the car, it will take the force of the impact and that mechanism injury for you, as opposed to you having no protection and wandering around out in traffic where no one's slowing down. And no one is going to slow down. There you go. But wait, there's more.
Talking about luck.
Just in time. I can fix it. Dad's a TV repairman. He's got an awesome set of tools. Any questions about scene safety, mechanism injury, number of patients? So based on all that, you'll record additional resources. Any questions? Other things to consider. Is there a threat? If there is a threat, and this will be a test question. If there is a threat, you don't feel the scene is safe, you back out to a safe area. You don't abandon the scene. You back out, you request law enforcement and more resources and wait for the scene to be secure. You don't clear the scene and go back in quarters. Hey, it wasn't safe. We're out of here. Any questions? All right, geriatric considerations. Geriatric is someone over the age of 65. May or may not have the first name of Jerry. So you have to look at are the conditions they're living in safe, and does the mechanism, injury, the nature of illness add up to the environment that they are in? Any questions? Big one that will also be on tests is if the patient's geriatric, they're confused, find someone that knows what their baseline mental status is. Are they normally fully alert and oriented and know what's going on, or do they have dementia or Alzheimer's? Do they not know what's going on? And if that's the case, is this their baseline, or are they more confused than normal? Make sense? Any questions? NOI stands for nature of illness. And it can be difficult to determine older people if they're severely altered or demented. Dementia, not demented. Any questions? And for any patient besides the geriatric, chest pain, shortness of breath, or altered level of consciousness is always considered serious. All right, so that covers scene size up portion. Any questions on scene size up? Let's move on to primary assessment. So what is your doorway impression when you first look at your patient? When you look at them, do they look like they're dead? They look like they're perfectly fine. They look like they're in severe distress. They look gray or ashen. Are they having difficulty breathing? What do they look like? What's your doorway impression? Then we assess the AVPU. Are their eyes open or are they alert? If their eyes aren't open, do they open when you speak to them? Annie, Annie, are you okay? If their eyes don't open when you speak to them, then you hurt them. Is their eyes open when you hurt them? No. If they don't, then that's unresponsive. If they do open to pain, then that's the P. One quick trick I like to use if it's a non-facial injury patient is lube up an airway, nasal pharyngeal, put it in. They don't respond to a nasal pharyngeal airway, be shoved into their nasal pharynx, they're unresponsive. And you've already secured the airway. They wake up to it, you woke them up. Strong work. Any questions? Part of your general impression is also what is the environment? What does it look like around them? Are they altered, lying in a pile of beer cans? I don't know what that is. Something weird. Okay. Any questions about a general impression of your patient? And we all look and see if they're bleeding to death. Don't want to miss uncontrolled bleeding, because if they are bleeding, you need to stop it immediately. Questions? You should always obtain consent. Identify yourself, your agency, and your level of training. Let her know you're here to help. And if they give you verbal consent, that's called expressed. And if they can't give you consent because they're too altered or unresponsive, that would be lied. And if they have an advance directive in writing, that would be informed. And if they're like, you ain't taking me anywhere, but they're a danger to themselves or others, or gravely disabled, and law enforcement agrees to do it, that would be good. You guys are learning. All right, chief complaint is what the patient feels is the biggest thing wrong. It may not be the biggest danger, but it's what the patient feels it is. Need to obtain it and document it. What if they can't answer any questions and their eyes are closed, they don't respond to pain? What's their chief complaint? Unresponsive. Any questions about ABPU? All right, so if they are alert, then you want to check. There's 4 different levels of alert. It should be oriented to person, who they are, place, which is where they are, time, which is what day it is, and event. Why are you there? If they are not, then they are alert and oriented times, however many of those things are. So if they're only oriented person and place, you say they're alert and oriented times 2 person and place. That's how you say it. If someone's one of the biggest mistakes that EMS makes, and I'm constantly, because I'm a CQI director, continuous quality improvement director, one of the biggest things I'm constantly correcting in EMS documentation is when someone's not alert, their eyes are closed, and they open to voice or they open to pain, they document alert to pain, alert to eyes open, or A&O times 0, DCS of 3, which means they're unresponsive. If they're unresponsive, their eyes aren't open, they're not alert. Alert is you're already eyes open and you're aware. Does that make sense? So don't do that. If you have a good CQI director, they'll send it back to you, your PCR. Then you have to rewrite it. Any questions? Any questions on AVPU? Any questions on person, place, time, and event? All right, then we check for a pulse. If they're unresponsive, we check. Unless they're a baby, then we check brachial. If they're alert and oriented, come up and do the paramedic handshake and check their brachial pulse. Any questions? And while we're checking it to make sure it's there, if it's regular, how fast or how slow it's going, and how strong it is. Any questions? And we're going to look for any uncontrolled bleeding, and if we find it, we're going to stop it immediately. Any questions? All right. Assessing the airway. We want to make sure it's clear and they're breathing adequately. Are they able to speak whole sentences, or can they only get 2 to 3 words out without having to take a breath? Do they have to use accessory muscles to breathe? Are they breathing so hard their nasals are flaring like a bowl? Any question? Or are they in obvious respiratory distress? They're all things we're looking for. They're unconscious. We want to make sure that their airway is open and clear. So we open their airway, either with a jaw thrust or a head tilt chin lift. There's no signs or indications of a mechanism of spine injury. Then we try to ventilate. Are they breathing on their own? If not, can we push air with a BVM? Do they have odd sounding noises? Or is their breathing shallow and slow, which is not adequate? You get a test question about slow, shallow breathing. Always going to be inadequate. Need to use the BVM to assist. Thursday night, I'm coming with a little white collar. I'm going to exercise this room. Make it do 50 jumping jacks. See if the demons will go away. Any questions? Exorcism's not a joke. I'm sorry. I had an uncle that they had to do one on. And it's expensive. It's like $40,000. You have to make payment plans. And he failed to make payments to the Catholic Church, so they repossessed him. All right. Any questions about possession in the church? All right. I think I offended the one Catholic in the room.
So cheesy.
All right. Assessing breathing. Make sure they're not choking. Make sure the airway is clear. Also, that they're not turning blue, which is cyanosis. We're going to go over how to take lung sounds tonight with a serial killer. I want to make sure that they have adequate air movement. You think I'm kidding? Wait till you see this video. Huh?
I said, I think I know what you're getting.
Does Sean use my presentations? I don't know if he uses my PowerPoints or not.
Some of them, not all of them though.
Oh, here it is. It's the next one. Look at this dude. Look at his eyes. This chick knows how to pick them. I'm telling you. All right. Here's this is a pretty good video though on how to do lung sounds.
Already not going.
Look at that dude.
We are back at 12 pyramid.
Or she's from the south. All right, here's Super West. He actually gives a really good explanation. These are what you're listening for. Thanks, Super West. Any questions?
Crackling, is that like when you put milk in Rice Krispie cereal?
Yes. One of them, one of the three. You also have Snap and Pop too. All right, high flow two. Gave you guidelines on that. So never withhold oxygen to someone that needs it. We used to like put everybody on high flow too, but nowadays we titrate generally to a SpO2 of 94%. If they're having a decreasing level of consciousness, watch for respiratory failure. This is a big thing that's missed in EMS a lot and causes your patient to die. So if you put them on high flow too because they're in severe respiratory distress, their respirations come down, but they become more altered and their SpO2 doesn't improve. That's respiratory failure. You start preparing a bag valve vasculated ventilate. If the respiratory rate comes down and they wake up more and they improve and they're not in as much distress and their SpO2 increases, that means you're going the right direction. That makes sense. So one of the biggest things people fail on, and I don't know where it comes from, but every semester somebody comes up with it. When they're doing their primary assessment for scenarios, they just come in and blindly order high flow too. Never do that. That's automatic critical fail. You have to assess the adequacy of breathing first. If they're not breathing adequately, high flow two is the wrong answer. That will be an automatic fail for you. For some reason, every semester groups come up with that. I don't know where it comes from. questions? All right. Try to get your patient in a position of comfort. If they're short of breath, that's usually going to be sitting. Of course, if they have a spinal injury, that may or may not be possible. Then you want to assess perfusion. So skin signs tell you more than vital signs do. Someone is pink, warm, and dry, it generally means they have capillary refill less than 2 seconds. We've done over capillary refill time. Pitch under the nail bed and the color goes away, whatever it takes to turn back to normal color. You count how many seconds. Their capillary refill time is under 2 seconds. They're pink, warm, and dry, or normal, warm, and dry. Generally, it doesn't matter what their blood pressure is or their pulse rate. Therefore, at least right now, they are getting perfusion to all the cells because your skin is the most distal cells in your body. Any questions? Things to think about pediatric assessments. So with kids, they're young and they're healthy generally, and they have incredible compensating mechanisms for blood loss and being sick. So they generally do not look sick like adults do. The big key thing to see if a child's in shock is your capillary refill time. They will have delayed capillary. It'll be over 2 seconds. If you have over 2 seconds with a child, you need to run. Start getting towards the hospital. When you're assessing a child, you should use your best friend, PAT. PAT is the Pediatric Assessment Triangle. And it's also based off of your doorway impression.
That Pat was what?
Pediatric Assessment Triangle. And it's a triangle, so it's got 3 sides. One is appearance. How does the child look? What is the child's work of breathing? Are they breathing normally or are they struggling to breathe? The last one is, what is their circulation skin? Do they have delayed capillary refill? Do they have abnormal skin signs? If a child has none of those 3 things, all 3 are positive, they are not critically ill. If they have one of those 3, they are a sick child. If they have 2 or 3 of them, it's a critically sick child. That's what you can tell right from the get-go, right when you walk in the door. If you bring Pat with you, you will know the status of your child right there in your primary assessment. Any questions? Pat is an amazing tool. Always bring Pat with you for pediatric assessments. Here we go. So let's go over each side of the triangle. So appearance, are they alert? Use the AVPU if they're not. Think about it, children, the best thing to do to kids, tickle them. So tickles is an acronym. What is the tone of their muscle tone? Are they interactive? Are they able to console them if they're not? Are they gazing or are they following you and tracking you in the room when they talk, when you walk in? And are they able to cry or are they able to talk? A lot of times people and children with respiratory failure aren't able to speak because they can't get enough air to generate a voice. So if they're at the end stage of respiratory failure, you don't see the labored breathing anymore because they've reused all their glucose. They don't have enough left. They're not speaking anymore and their breaths are shallow. That's impending respiratory failure. Anyway, that's part of the appearance side of the pediatric assessment triangle. Any questions? Next one is circulation. Kids should not be pale, but the biggest thing is capillary refill time. Any questions? Modeling is also common to see in kids, especially if you take them out of a bathtub in a cold environment. they'll immediately shut down. That is also a sign of possible shock, but not nearly as accurate as capillary refill time, which is abbreviated CRT. I see on the test is CRT. Any questions? All right. ABCs, then XABC. Are they bleeding to death? Is their airway clear? Are they breathing adequately? Do they have a pulse? You do not pass go. You do not do anything else till you have secured those three things. Nothing else matters. Any questions about XABC? All right, then airway. Airway should be clear and respiration should be adequate and unlabored. Any questions? You guys all understand Pat? If Pat is poorly understood, your patient's not going to do well. Got to make sure you understand Pat. Always bring Pat. Again, breathing must be adequate and not labored. Questions? All right. Again, circulation. Capillary refill time. Do they have a good pulse? Is their skin of normal color, warm and dry? But CRT is going to be your key factor. Any questions? AVPU works the same. They're not alert. Speak to them. Their eyes open to voice. Their eyes don't open to voice. Pinch them, hurt them. Their eyes open to pain. Their eyes don't open to pain. They are determined to be unresponsive. All right. Then exposure. So kids, we generally start, this is still primary assessment. You got to make sure that you can see their chest, make sure their chest wall is rising symmetrically. Look for any other voyages, but kids also are huge radiators. They don't have a lot of body. I guess we should go over it now. Usually don't go to the burns, but so I have a piece of paper here. The surface to mass ratio, kids. I'll explain to you surface to mass ratio. So if I were to light this on fire, the edge here, how quickly would the sheet of paper burn up? Fast. Literally in about a second, right? And I take the same sheet of paper and I crumple it up into a tight ball. And I light a lighter to it. It's going to take that big to burn. A long time. So the mass is still the same, but it has a greater surface ratio, which expels the heat faster. Does that make sense? So kids have a larger surface to mass ratio than adults do, so they lose heat faster. You got to make sure you keep them wrapped up, keep them warm. Any questions? Priority patients, any child or anyone that has these things, or any child that has at least one positive finding on PAT, the priority patient. Based off your ABCs, your primary assessment, you're determining, do you need to load and run now? So this includes adults. Anybody that's got this, need to start moving towards definitive care. Any questions? Any questions? That's the thing. Am I going to do a secondary assessment with history of vital signs, or am I just going to load and run? That's based off your primary assessment. Any questions? All right. We got scene size and done and primary assessment done. What's next? History taking. First medical ship to make it to the United States came in 1492. Just kidding. That's Columbus. Italian joke. Sorry. You guys don't know about 1492. Columbus discovering America. Yeah. Got here. He declared it Indigenous People Day. Rough audience. Public schools are failing me. All right, history taking. So we get the chief complaint. I know you guys have already gone over sample and OPQRST, but we're going to go over it again. The chief complaint is the most serious problem voiced by the patient. May not be the patient's most significant problem. That's the chief complaint. Then we're going to go over sample history. So the OPQRST just defines the symptoms in sample history. So we're in sample, S is signs and symptoms. A sign is something you can hear, see, feel, smell, or touch. Well, feel and touch is the same thing. A symptom is something the patient tells you. So the symptom is then you can drill down on the symptom using the OPQRST, which we'll go over in the next slide. So after you have your signs and symptoms obtained, you want to know if they're allergic to any medications. So the paramedics or the doctors don't give them something that'll kill them.
You want to ask if they're allergic to anything else like bees or?
Yeah, but medications is the big one.
Yeah.
I mean, those things are nice to know, but they're not critically important to a patient assessment.
Okay.
Then medications, what medications they are prescribed or taking that even aren't prescribed, self-prescribed. Because again, you don't want the paramedic or the doctor to give them a medication that counteracts the medication they're on and kills them. And you want to know their past medical history, which will help you with your assessment. And last meal is critically important because they have to go in for emergency surgery. It's going to determine what type of meds and stuff and how anesthesia puts them under for surgery so that they don't vomit and then choke on it and die from aspiration. Then E is the events leading up to it, because that gives you a good clue of how this environment was created and how this patient got sick or injured. Any questions about the sample? And we're going to go into OPQRST, which is drilling down on the symptoms. No questions. Yes, we're not going to do OPQRST right now. So O is for onset. When did this start? P is provoked. What caused it? Q is for quality. What does it feel like? Can you describe it? R is for radiation. Does it go from where it starts to radiate to the other part of the body? S is severity. How severe is it? And T is for time. Is it episodic? Does it come and go in episodes? And how long are those episodes? Or is it a constant complaint? And that's how you drill down the symptoms on your sample. Any questions? So in pediatric considerations, most of them are not able to give you a sample history. So you got to find a sibling or a parent, or hopefully have a type of informed consent. Any questions? Also, kids, when we get to the secondary, not sure if it's in here or not. On adults, we go head to toe. On children, we go toe to head. Guys, because kids freak out when you go straight for their head. So you work the assessment up. Any questions? All right. I have nothing to add to this. Any questions? No questions. All right, geriatric considerations. So kids, we had the PAP, which is the pediatric assessment triangle. Geriatrics, we had the GEMS diamond. We also look for informed consent, vials of life, advanced directives.
Your attention, please.
There's your Jim's Diamond. Is it a geriatric patient? Is their environment safe for them to be in, and is it a factor in what's causing this problem? What's their medical history and medical assessment, and are their social needs met? Or is everyone around them dead? Any questions? Jim's Diamond. Sensitive topics, alcohol, drugs. Never be accusation, just ask. If you had anything to drink, if you taken any drugs, any self-prescribed medications, do it in a non-judgmental way. Always be professional. You document that you smell alcohol in someone's breath. You don't put smelled alcohol, you put smelled ETOH, chemicals. So physical abuse and violence. You're going to be a mandated reporter. You're not the investigator or the trial jury. You just report. So if there are flags of physical abuse or maltreatment, you have to report it to the investigative authority of power. Don't accuse, just report. Any questions? The better your documentation, the better the case. So have good documentation. It's essential. Any questions? Again, sexual history is a very sensitive topic, and should be done in private if it is a factor in the patient assessment. Any questions? All right, that covers history taking. Are you ready for the secondary assessment and vital signs? So on trauma, we try to do what's called a killer search. It's a 60 to 90 second head to toe looking for significant trauma and what's going to kill them. What we're looking for is DCAT BTLS. When you go to your assessments and you're in your scenarios, you say DCAT BTLS, proctor's going to call you out on it, so you better be able to recite it. That's pretty much what you're looking for when you're doing a head to toe. Any questions? Right. Huh? Just see people. So C-spine's a question. Make sure you don't let go of the head. Check the chest for DCAT BTLS. Listen to lung sounds. Check the abdomen for DCAT BTLS. You're going to assess the pelvis. All four extremities. You're going to look for distal circulation, sensation, and movement. Package your patient for transport. The vital signs. If you're with a patient for more than 10 minutes, you should have at least 2 sets of vital signs. Your first set of vital signs is always your baseline. Doesn't tell you much, so you get a second set to see if the patient is improving, staying static, or getting worse. If it is a critical patient, you should be taking vital signs every 5 minutes. That will be a test question. Now, all that said, never, ever, ever treat a patient based on numbers from a vital sign. You need to look at the patient as a whole, all your signs and symptoms, all your positive findings, including vital signs, form a primary impression and treat the primary impression. Never treat anything off one number of vital signs. Any questions? They call that treat your patient, not the numbers. What are vital signs? Skin signs? blood pressure, pulse, and respirations with SpO2. And you guys have to know Glasgow Coma Scale. There it is. Cool thing about the Glasgow Coma Scale that I really like about it is even dead people get a score. If you're completely unresponsive or dead, you'll still get 3 points. It's a great consolation prize. So, first category is eyes. You guys already know that it's your AVPU. It's just rated on a point system. They're alert, they get 4 points. Their eyes open to voice, or they get 3. Their eyes open to pain, they get 2. If their eyes don't open at all, they still get a point. Then we got verbal. They are alert or they oriented to person, place, time, and event. If they're not, then they go to 4, confused. If you can't even get that out of them, they're going, oh, well, I don't know what the heck is the cat's peeing in the food. And they're not making any sense. That's inappropriate. That's 3. If you can't even understand what they're saying, all they're doing is going, that's 2 points. If you don't get any verbal at all, it's 1 point. Then the last category is motor, and we're going to test you on this. You guys got to know this. If they can obey commands, they get 6 points. If they don't obey commands, they localize pain or they have purposeful movement, it's 5 points. If they pull away from you when you hurt them, that's 4 points. If they're having decorvate posturing goes towards the core, you go like this, that's 3 points. If they have decervate posturing, which is like this, that's 2 points. And if they're not moving at all, they have no motor function, they get 1 point. So you take all 3 categories, you add them together, that's your Glasgow Coma Scale. And you want to see some good videos of extension and some flexion? So when you get your bell rung really hard, someone knocks the literal snot out of you, especially in sports, have what's called a fencing response. Their arms go straight out, and then sometimes they'll do a little bit of decervate posture. Not quite decervate posturing, but it's close enough. You guys want to see it? You want to watch videos of people get the snot knocked out of them?
I want to see what it looks
You
like.
guys are morbid. All right.
Kind of the whole point of the.
I guess I'll let you see it. I'm done. Playing soccer. Oh.
Have it.
Live TV. All right, any questions? You have a pretty good idea what that looks like now.
Long video for one thing for an already.
Shows you how often it happens, though. So remember, go toe to head on kids instead of head to toe. Also, kids' heart rate is going to vary. Same with blood pressure. If you're under 3, we generally don't even get a blood pressure, but the capillary refill time and skin signs, the key indications on little tykes. Any questions? Geriatric times, geriatric examinations. Got to give them time to answer questions. They actually think about their answers. And they're probably not okay with you cutting their clothes off. So make sure you explain everything in detail what you're doing. Any questions? Then we reassess. Any questions? Do a more detailed exam. This is during transport if you have time. Look at all the extra things. Any questions? Any questions? Any questions? Then we look at all the positive findings, form an impression, use a treatment protocol based off that impression. Treat the patient. Any questions? Always listen to lung sounds. I want you to listen to lung sounds on every patient. It's a critical fail if you don't. I want you to listen to a couple thousand lung sounds here in class, that when you do get abnormal lung sounds, you immediately know. I've listened to hundreds of these and I know that ain't right. Any questions? Pelvis, you press down and in if they don't have pelvic pain. If they tell you they have pelvic pain, we don't push on it because we don't want to move those plates. Any questions? Ta-da! Vital signs. Every 5 minutes on critical patients, 10 minutes on non-critical patients until you have turned care over to someone of equal or higher level of care. Any questions? Reassessment. Any questions? If someone has a change in level of consciousness or a major change in condition, you immediately repeat the primary assessment. That will be a test question. You have to know that. Any questions? All right, here is an example of what you'll be expected to do. What we're going to be doing pretty much every day from 8 to 10 for the rest of this class. This is performed by, at the time, paramedic intern Warren Bree. That's exactly how it should work. You're gonna be able to do this by the end of this class easily. That's not his first time doing it. He had to do that literally hundreds of times in a row before he got that good at it. Hundreds of times. It's over 10 years ago.
I know, they look like it's over 10 years ago. Bethany pretty much looks.
A lot of people in that video aren't even alive anymore. All right, so this is how we do rapid fire. This is what you guys will be doing. You do one thing wrong, we're gonna send you out of the room. The next person takes your place as the leader. We just keep going in the batting order. Actually, this is not rapid fire. I lied. The actual students doing it. How young like Proctor is. Never goes quiet. sure you know how to use your equipment.
Then two. Attention, please. Your attention, please. Ten three.
Pages on the gurney backwards, by the way. Where the feet go. Couldn't figure out her general impression. Oh, we had the. Oh. All right. Your patient is a 6-year-old female to complain of right flank pain. She's alert, normal, warm, dry skin. She's been placed with oxygen. You obtain a focus history. What should your partner be doing? Should they be preparing an ambulance stretcher? Is that a good answer? Yeah. Should they get a set of baseline vitals? Is that a good answer? Yeah. Is it a better answer than A? Yeah. Should they gather the patient's medications? Yet another good answer. Is it a better answer than B? Should they repeat the initial assessment? Is there any reason to? No. So what's your best answer? B. You arrived on scene of a crash. Your patient's 22 years old, sitting in the passenger seat. He's conscious, alert, and has no visible trauma. Is complaining of neck and back pain. Before taking him out of the car, you should perform a detailed head to toe and apply a cervical collar. Good answer? Yeah. Maintain manual stabilization of his head and grasp him by the clothes. Is that a better answer than A? No. He doesn't need an emergency move. He has no signs of trauma. Apply a cervical collar and immobilize it with a vest style device. Probably the best National Registry answer. Or D, put a scoop stretcher. We know that's not right. So what's your best answer? Your patient is an elderly male who's very confused and short of breath. He's on the 4th floor of the apartment building. You're extricating him. Suddenly he becomes unresponsive. Your partner advises he's not breathing. Patient, not your partner. What do we do when someone changes level of consciousness? First thing we do is we reassess what? Very good. So place a spine position where you begin to work and start CPR. Is that a good idea? How do you know he needs CPR? You don't. He could be not breathing and still have a pulse. Begin CPR and continue extrication of the ambulance. That's going to be hard in a stair chair. Is that a better answer than A? No. A is the better answer. It's the least bad answer. Begin ventilation with a BVM, check for a pulse while your partner prepares an AED. Is that a better answer than A? Absolutely. Open the airway and continue extrication of the ambulance. Is that a better answer than C? Your dispatch to unknown medical, you find a 52-year-old male sitting in a chair, sweating, pale, and cold. That's not good. You note that his pulse is rapid and irregular. In addition to giving him oxygen, you should transport at once, consider requesting a paramedic unit. Bad answer. Not a bad answer. Document your findings before a rapid medical assessment. Also good answer. Is it better than A? Oh, we should probably get this guy moving. The priority patient. Include the irregular pulse is normal because he's old. Contact medical to get medical control to get an order for nitroglycerin. Is that a better answer than B? Was B a better answer? No, A is the better answer. D, apply a cardiac monitor, observer cardiac rhythm. Do you guys use cardiac monitors? Tom says that's the best answer.
Oh, hi, Tom.
I think we should go with A. 56-year-old male is found semi-conscious by his wife. Your assessment reveals he has respiration shallow and rapid. It be adequate always on these tests. His pulse is rapid and irregular. His blood pressure is low. Twice he's complaining of left arm pain and nausea the day before, but will not allow her to call 911. Most consistent would probably be A, cardiac hypoperfusion. A good answer? Not bad. B, a ruptured aortic aneurysm. Better than A?
I don't think so.
How about an acute myocardial infarction? That's a heart attack. I think that's better than A or B. Severe septic hyperperfusion has no signs, symptoms, sepsis, but you haven't even learned about yet. Oh. Alrighty then. We'll do one more, then you guys go to break. 67-year-old male presents weakness, dizziness, and melena. That's black poop. Usually means blood's in it. He has no history of trauma. His blood pressure is 90 or 50, pretty low. Heart rate's 120, pretty high. You should suspect that he's experiencing intestinal bleeding, black stools, blood in his poop, low blood pressure, high heart rate. That's a good answer. Intrathoracic hemorrhaging, would that cause you to have bloody poop? No. Appendicitis, would that cause you to have bloody poop? Aortic aneurysm, would that cause you to have bloody poop? All right. Go to break, be back about 5 minutes after 8, ready to learn how to grab tools and equipment and all that fun stuff.